Hi, everybody. My name is Dr. Diana Obidniak. I'm an affiliated professor of main St. Petersburg University in Russia. It's located in Russia and in California. Thank God, unfortunately, I don't know. So I'm a fertility specialist, and medicine is my, main passion in my life. I love what I do. I love my patients, and now I'm going to present you um, what we can do right now. We will talk about IVF and recurrent implantation failure. Pittsburgh. It was like the first recommendation after my presentation in the conference in the United States. And I've shared our experience, which was rather exclusive for that time. After years of fruitful work, by this time we have already so-called Doctors Diam fertility team, and we have very intensive experience collaborating with international patients, even right now during lockdown and pandemic issue. So I believe, and all the members of my team believe, that everybody deserves to become a parent. And under this idea, we live our lives, we build our collaboration and our practice. Our team is known for expertise in so-called tough cases. We understand that nobody goes to another country when we're talking just like ordinary conventional problem. And it's our experience that we had to face very exclusive and very tough cases. So by this moment, we have already patent for algorithm in management of recurrent implantation failure. We have strong specialization in severe endometriosis, in patients of so-called advanced reproductive age and poor ovarian reserve. By this time, we have approved pregnancy guarantee packages approved by evidence-based medicine. I'm not only a physician, I'm a passionate investigator. That's why each our recommendation and each word of my team is strongly approved and criticized by evidence-based medicine. So I'm take responsibility for each word, for each recommendation of each member of my team. But for us, it's not just a work. For us, this place it's a cozy and elegant home for both, for patients and fertility specialists. So 9 years ago, in 2012, I started my fundamental study on IVF and on recurrent implantation failure. To say the truth, I was ready to, be like a Dr. House and working with interesting and so rare situations with like exclusive problems. But I faced so many patients with ineffective IVF attempts. The toughest case was, and we call her, and she calls herself also the champion of Dr. Diana, because she come to me for her 26th attempt. She already had 25 IVF attempts with no even biochemical molar pregnancy, with no positive test in her life. She already wasted more than 12 years for that period of time. She struggled a lot, and she had no, practical recommendations, because she was recommended only to keep on trying or quit. But I always admire of how brave my patients are, how strong women are. So as a result, I dedicated all my time, all my energy, inspiration to create approved practical guidelines. And now we have 4 international awards from American Society, from European Society. Because of it, I became a national representative of Russia at Europe. And now we have even 2 patents for invention for this algorithm. So that's why we bold to provide pregnancy guarantee package. What does it mean? For us, I understand that, and I can relate how significant is to give your trust to anybody, especially for physician, especially in such a delicate area like reproductive medicine, like in vitro fertilization, because even we have implemented controlling system, so-called witnessing system, and and now everybody can be sure that, no biological mistake can exist here, but it's still an area where one should trust another to another. So pregnancy guarantee packages, it's when clinic also take responsibility on even financial part. So you don't have to trust my words. You will see the results. But till that moment, you know that clinic is also interested in your very short time to pregnancy. And we will do our best, not only because we do relate how significant it is, but also, the owner of business will provide some problems to me if I don't help you. It's a joke. So our secret in brief. I believe that, each big aim, it's better to divide into small parts, into small tasks. And for me, when I made for the first time each couple, I'm trying to, write a book for them. So we go throughout your treatment, chapter by chapter, and we do not go to the next part without making previous one done. Sometimes one chapter takes just, 2 days, but sometimes one chapter can be the crucial part, and it takes 3 months or 6 months. But it was the only problem we had. And after determine what solution will be fruitful precisely for your couple, we have no problems with the rest of the book. So our idea is not to make you pregnant. It's not to receive positive tests on pregnancy. Because I'm the physician who is not, struggling with infertility. I have in my arsenal a lot of methods, a lot of techniques. That's why we can implement them to solve many problems which are not associated only with infertility or problems with conception. We collaborate and we help patients who just have problems with even somatic problems, but they have contraindications for stimulation, for childbearing. Or sometimes it's just for they have problems with the first period of implantation. So our aim is to bring you healthy baby home, and our aim to make it as fast as comfortable as possible. So one embryo transfer, one healthy baby. So let us go through this book. Introduction, the very beginning of your pregnancy. We call it the implantation. It's a process of delicate interaction between the embryo and the endometrium. And from this time, it looks even surprising, but several years ago, it was less than 10 years ago, we were sure that there were just 2 main players in this process, the endometrium and the embryo. But now we know that there are a lot of, of second role. Camellia cells, microenvironment, and various growth factors play an important role, and they program it or hindering successful nidation. So now we talk about, for sure we have even more main players, but we will discuss, and given the limited time, the embryo, the role of endometrium, and the role and influence of concomitant pathology. So chapter 1, the embryo. According to actual fundamental knowledge of all human beings, we know that there is strong correlation between the prevalence of abnormal or normal embryo, and morphological quality, like, good looking of the embryo. And we know that, unfortunately, even when we talk about the most healthiest girls in this world and the youngest men in this world, and we will, imagine such a couple, we know that when we talk about embryos, we have several qualities. For sure, there is an international morphological evaluation system, but we have to talk on simple words and to be very transparent for our patients. That's why all physicians, all the biologists, the embryologists determine to make a distinguishing and call the quality of the embryos like excellent, good, average, and poor. So even among the embryos of the excellent quality, not more than 56% will be normal. When we call normal, we mean that genetic status of this embryo is healthy. So that's why we have to implement preimplantation genetic testing. It's an investigation which gives us the strong result. With a strong responsibility and transparency, we can know which of the embryos is normal. So this investigation allows us to investigate all the 24 pairs of chromosomes, because once again, our aim is to bring a healthy baby. I know how I have very close relationships with my patients, and that's why I know what a drama is to have pregnancy after such a long period of struggle, but to understand during the pregnancy that unfortunately there are some problems, and you are the only person who is responsible to take this decision what to do next. I don't want to bring my patients to this traumatic situation, to this point. I want to present you one trial because, about even 7 years ago, we were so persuaded that when we implement egg donation programs, in some countries they are widely recommended. In some countries they have limited, acceptance because of some legal features. But according to the evidence-based medicine, we will talk only about medical issues. We were sure that if we implement egg donation, so we use the oocytes of very young, of very healthy, of checked and examined for all the genetic points girl, we know we would just certainly get healthy embryo. But unfortunately, right now we understand that no, it's not about that. For sure, we have to implement genetic examination, and from year to year it becomes more and more accurate, more and more advanced, and it takes and it seems to be never ending, to say the truth. But even when we talk about egg donation, I want you to see just the results. There were division into two groups. Group A with 188 egg donation with PGT programs, and Group B, 58 egg donation program without PGT. And when we talk about implantation rate, it's not live birth rate, it's just how many embryos implanted. Group A, only 46% was implant even with PGT. I have some questions because it's rather low effectiveness for egg donation program. But we see that in Group B without PGT, it's 2 times lower. And these rates and this correlation, it's quite the same. I don't want you to, pay attention to the figures of 46 and 20, because it's rather low for all programs, even without egg donation. But I want you to remember these relationships, because even in egg donation program, and especially when we talk about IVF with the own eggs, for example, after 30 7 years old, these relationships will be even more dramatic. So also, the other, actual data of nowadays, we know that not only woman is the person who is responsible in outcome, because usually, usually from the very beginning of this area, now we have already experience of the 40 years. So we know that is totally safe, and we have already babies who enter in the university. So we know that they are even more intelligent against all the myths. But by this time, we know that the sperm of quality, the quality of sperm, do makes differ, and it really plays a huge role, not only in outcome, but especially in genetic status of the embryo. It's different types of genetic abnormalities. To say the truth, when we talk about preimplantation genetic testing, there is no difference what the problem inside the embryo. To say the truth, we should we will have and we will be satisfied only with one response, that the embryo is healthy. All others results for sure will provide different tactics, different solutions, but we want just one. We want, best or nothing. So, embryo in terms of GCP right now, selection, and selection. In my mode of view, IVF, it's all about selection. Because human nature always is much wiser than we, unfortunately. We can just mimicry and try to be quite similar to the nature, but we have to enhance our practice and select the better embryo, the better time, and the better place. So right now we have enough, to say the truth, enough instruments to select. So we can have and use specific incubators, so-called embryoscope. It's a time-lapse cultivation of embryos. It means that with no interruption and with no additional intervention to the embryo, we observe the process of development of the embryo. And artificial intelligence, which seems to be much cleverer than some biologists, help us to select which embryo is perfect. Then we for sure implement PGTA. It's preimplantation genetic testing for aneuploidy, so it means abnormal embryo, and PGTM. PGTM is specific situation when unfortunately couple has an experience of having defected offspring. I don't want to tell this word, but for sure we all are, carriers of some monogenic diseases. Each one, especially me, for example. But, thank God it makes sense, and it makes any practitioner complications when we meet the person who has just the same number of careers. That's why when we talk about egg donation, we always recommend to make panel of genetic investigations, because for sure she is pretty genetically perfect, but when you meet another person, you never know what experience, what medical history from different generations we carry. So, for sure, normal practice right now is selective transfer of one embryo. No doubt in natural life we have multiple pregnancies, but it's like a decision of destiny, and for sure we know how to deal with that. But when we talk about our project, let us call fertility project, let us make it perfect from the very beginning and minimize all the risks. So as our idea is to have healthy baby, we want to minimize the risk. Even when we talk about natural conception, trust me, I always tell my students that multiple pregnancy, even in conceived in natural life, it's assessed and is considered to be abnormal pregnancy. It's not a kind of we sure that babies will be abnormal. No, but we know that we assess it as a risky pregnancy, and we pay much more attention to each day of this pregnancy. So we practice safe, and sometimes for sure, if the dream of couple to have boy and girl, or never mind, two boys, two girls, just twins, they dream with that, they fall asleep with this idea and wake up with this idea. We discussed for many weeks trying to assess all the risks and advantages, but last year I had just one couple like that, but now I see they seem pretty happy. Maybe they just closed this idea with babies after having two, because it's a stress after delivery to deal with two babies, two new persons in your house. So, chapter 2, the endometrium. I will remind, I see that we have men in auditorium. Now, endometrium is the inner layer of the uterus of woman. So, also, traditionally, endometrium was like a microenvironment, which is like an apartment for pregnancy, but it's not that important. Now we know that it is very important, and it is apartment for future baby, but people are so have so many ideas how it should be, how what conditions should be around that. If they do not like uterus, precisely endometrium, the embryo will not implant. That's why we have to take into the account the quality of endometrium. Now we know that endometrium is a kind of biosensor of embryo quality. So it is characterized with two strong features: receptivity, so it's a capacity to accept the embryo, and selectivity, to hinder its implantation. And we have two mode of alterations: morphological, which is associated with some defects inside, and functional. It's like a bad mood of endometrium. So if we talk about morphological alterations, we can distinguish three main processes: inflammatory process called chronic endometritis, hypoplastic processes, and intrauterine synecher. It's like a strong adhesions, connections between the layers of the uterus. Most of them we can find with a routine ultrasound scan. But chronic endometritis as an inflammatory process, it's not the thing that we can, admit and verify with our own eyes or some methods of visualization. No, it's a condition involving the breakdown of the peaceful coexistence between microorganisms and the host immune system. The thing is that you will not feel any, strong, severe processes inside. Maybe you will notice after several months that your menstrual period is a bit different. For example, the period is becoming a bit brownish, or the flow is too large or too small. But the clinical signs are non-apparent. And that is the bad thing in diagnosis of chronic endometritis. If you see to this slide, you see that the prevalence of chronic endometritis differ a lot depending on the study group. So if we talk about just general population, it's not more than 10%. But if you pay attention to my ordinary patient, it's like recurrent implantation failure with good quality of transferred embryos, or just recurrent implantation failure, or recurrent pregnancy loss. It's two or more cases of pregnancy loss for different reasons. You will see that it's from 45 So a half of patient to 66% of the whole generation of such kind of patients. Also, we know why we have such results. You know, in 60s, in 1960s, we were pretty sure that the uterus is sterile, and nobody can live there except our babies. But no, there are too many lives inside, to say the truth. And if we make a huge jump to actual data, we know that when we can implant sequencing, it's genetic testing, when we can detect everybody who lives inside any material, even bottle or with water, we know that there are residents, tourists, and invaders inside the uterus. And this so-called microbiota plays a detrimental role in recurrent pregnancy loss, in recurrent implantation failure, in the conditions which exist inside the uterus. Because, let us tell once again, the uterus is an apartment, it's a home for our embryos. So we know, and by this time we already make in routine practice, we try to determine the type of this microbiota. Is it beneficial for embryos, or it's aggressive, and we should treat it before? So our idea not to make trial embryo transfers. Our idea to make approved investigations before trying. That's why from the first attempt we have more than 62% of successful embryo implantation. If we talk about functional alterations, nowadays it's even not surprising, and I bet that most reproductive or so-called fertility specialists know about this problem. It's a compromised window of implantation. About 65% of women has like certain time of her menstrual period when her endometrium will certainly accept the embryos. All others, it's about 35%, it's not that small generation, has her own specific window of implantation. It also takes about 48 hours in a month, and only during this period of time, only 2 days during your menstrual cycle, you are ready. And it's not always associated with ovulation or LH peak. No, we have to investigate it. So we have 2 tests, error test and be ready test. They are quite similar in result. They are just made in different countries. But as a result, we have personalized embryo transfer. We had a bit limited time, but I want to share with you the samples of analysis report. So given we investigate the samples of endometrium, and we indicate when we make the certain even hour, a certain time when we make this sample, we indicate how the durance of progesterone installation, and then as a result we see, unfortunately, I don't see diagram here, it's rather beautiful, but we see all the information we need. It's post-receptive, is a general outcome, or pre-receptive, but we want to see receptive one. So post-receptive, it means that endometrium is too mature. He is just tied to wait. So this cycle is already not good for embryo transfer. And pre-receptive, it's just no, it's not ready. It should think over maybe for another cycle. But embryo, it's a treasure. It's not the thing that we can waste just for try once again or try another one. That's why we want to get as much information as we can. Chapter 3, Concomitant pathology. For sure, we have many situations, and it's not in general situation, just we have specific, when you have reputations to work with tough cases, everybody comes with very interesting stories. So, factors associated with concomitant pathology. Hereditary thrombophilia. It's also very interesting that just in 2006, we thought that 2 or more thrombophilia factors could provide effect. Now we know that just only factor 5 mutation and MTHFR homozygous mutation plays a role, nothing else. Because during this period of time, we had tendency, in medicine we also have fashion things, and issues with thrombophilia was in fashion. So we had a lot of recommendations from different physicians to give more tablets, more pills, more infusions, and we never saw the result. Now we know why. Also, factors associated with concomitant pathology, immunological factors. For sure, unfortunately, we have not enough time, but there is strong association between uterus, thyroid, and ovaries, and it's under your function of your immunological system. So these are conditions which we should take into account, and for sure we have different layers of investigation. We try with the basic one, and if we have some problems, we keep on investigating and go deeper and deeper. As we have told already, factors associated with gametes and embryos, but with not associated with genetic status. It's like functional capability of camelus cells, the effect of the ovarian stimulation protocol. Well, in different countries, there are different approaches. Now, to say the truth, we have 19 types of ovarian stimulation. So trust me, there is a huge chance that we will obtain egg. It's just, to say the truth, we will obtain the egg, but it's not what we want. I want to bring you healthy baby. I always obtain egg, but unfortunately, we cannot just go against the nature. We should have information and never provide you just inspiring but false information. So one point which is very, very important, it's male factor DNA fragmentation, because not only genetic status is like a conclusion as a result of quality of sperm. If we talk about morphological issues of sperm, so-called strict criteria of Kruger, yes, but also there is a kind of DNA fragmentation. It's like the result of chronic stress. Tell me who is not under chronic stress. I don't know such persons, but unfortunately, if we do not struggle with that, fortunately, the solution is pretty simple. It's just antioxidant therapy, but it can result in pregnancy loss, even after PGTA, when we know that the embryo is genetically normal. But unfortunately, it's a bit, it has such an adverse effect during this development because of DNA fragmentation that unfortunately it already induced and ruined for development. So, conclusion. Our IVF success is not just a good embryo or positive pregnancy test. It's when you take your healthy baby home. My cell phone is full of, pictures of babies coming already to school, and I think that I'm too old for all of this, but it's the thing which makes us full of energy and full of inspiration to go once again and once again. I want to share with you, like in afterwards in the book, I want to share with you with one case report. It's a woman, 39 years old. She had already 8 embryo transfers with preimplantation genetic testing and no result. Even molar pregnancy, half minute. We performed hysteroscopy treatment of endometriosis, and she got naturally conceived. We made a non-invasive prenatal test because we couldn't make PGTA, it was natural conception, and we had delivery. And another one, 41 years old, she had 27 embryo transfer, my champion, and she had endometriosis 4, it's the most severe stage, chronic endometritis with severe activity and autoimmune component. We applied own egg program with following PGTA, hysteroscopy, deletion of micropolyps, delayed frozen thought embryo transfer in natural cycle, and as a result, the clinical pregnancy delivered with health boy in 2018. Now in pandemic 2020, we made her 29th embryo transfer. We had already delivered, to say the truth. So now she had boy and girl. So take care of yourselves. Thank you for coming together. We are certainly stronger. If you have any questions, just don't hesitate to contact me or my manager. She speaks German pretty well, better than me. So thank you.